Hello and welcome to this webinar hosted by Royal Canin entitled Best Practice Dermatology Case Management. My name is Debbie Simpson and I run a practice in Auckland, a specialist dermatology practice called the Skin Vet. I've got three lovely nurses, Bryony, Emma and Ellie, and I'm a registered specialist in veterinary dermatology. I completed my residency and passed exams in 2014. To start with, I want to say thank you very much to Royal Canin for hosting this webinar and also for their commitment to and support for veterinary dermatology. It's very sad this was originally supposed to be an in-person meeting, which would have been really lovely, but unfortunately level 4 and Delta paid to that. So hopefully we'll be through this current outbreak by the time you're viewing the webinar and enjoying some freedom again and hopefully some better weather. Dermatology as a discipline can be quite frustrating. Often the patients never seem to get better and the owners can be quite demanding. So during this webinar, I'll give you the best tips that I learned in my 3-year dermatology residency and since. If I were to summarize them now so that you can bail and do something more interesting and just this one screen as the takeaway screen, then I would say it's really important to get some good reference resources, to give yourself enough time to do a thorough consultation, book a double appointment or whatever amount of time you feel you need to do a good job of the consultation. And probably the three most important ones that I've highlighted are that it's really important to manage owner expectations so that you don't feel like you're on the back foot. This is something perhaps more for new graduates or recent graduates. Once you've been in practice for a while, you learn that this is one of the most important things you can do, is to give people a realistic idea of what they can expect. Always do your best to get an accurate diagnosis. That goes without saying. It's going to make your job a lot easier. And do cytology in every single consultation. It would be really rare that I would do a consultation without doing cytology. Don't be scared of doing biopsies. Sometimes that's the quickest way to get to an answer. And once you've done the consultation, communicate with the owners and check in about the patient constantly. It's amazing how much gets lost in translation and how things can go off track, especially if you're doing things like diet trials. And this is, again, something that I've learned from experience, is that there's no one solution that works for all patients, even if the diagnosis is the same. So start out with what you think is going to be the best option. And if something isn't working, then don't be scared to try something different. Some good textbooks are, if I could only have 3, these would be the 3 that I would have. The Plum's Drug Handbook comes in an online edition as well as a physical edition. I use this probably daily or multiple times a day. The main dermatology text is Muller and Kirk's Small Animal Dermatology, published in 2013. I think they must be due a new one in the next couple of years, but this is a really good resource to have. And then a good cytology textbook like this one by Francesco Albanese is also something good. The contents list on the right-hand side are from the Small Animal Dermatology text, and you can see it starts out with basic anatomy and then goes through therapy and then divides all the diseases up into infectious, hypersensitivity, etc. So I also would use this at least on a weekly basis, if not daily. Before you get started, you really need some basic tools. An understanding of the structure of the skin is critical. Just like when we started vet school and started learning anatomy, you just need to know the structure before you can get started. Also, some terminology about how to describe lesions, and probably most importantly, how to do cytology. These skills are really important if you're sharing cases between vets and also for your own reference if you're the only vet, because good examination and record keeping lets you quickly see what's been done and discussed already what's improved or not since the last appointment, and also some of the basics that you need to know, such as whether there's a seasonal pattern to the problem. Do the clients always come in January with the same problem? That will give you a clue that it could be environmental allergies that are the reason for their pruritus and dermatitis. I have the same approach to skin disease as we learned at vet school, for just having an acronym for working through all the possibilities of what could be the starting point for generating a differential diagnosis list. And I just made my own one up, which I called Cat Mind, because for me that's just an easy thing to remember. And I sort of tried to start with the earliest problems, the congenital problems, and then moving on to allergic or autoimmune, then traumatic and toxic, metabolic, infectious, nutritional, neoplastic, degenerative. You can obviously flesh this out, make it up in an order that makes sense to you. And it's just a good starting point, especially on those ones that you're really kind of trying to work from first principles. So there's just a diagram of the skin there with the basics on, just showing the structure of the skin from the epidermis, which are the very top layers, and then also showing the distribution of structure, adnexal structures such as sweat glands, nerves, blood vessels, hair follicles, and fat. The structure of the skin, just a slightly different diagram. The cornified envelope is the very top layer of the epidermis. So at the moment, we're just in the epidermis, and basically the basal layer contains the stem cells which proliferate, and then the skin cells gradually mature as they progress upwards through the skin. So they gradually lose the nucleus becomes the nucleus is lost and the skin cell is flattened out. The keratinocyte lipids are extruded, and finally the skin cell is desquamated or lost. So when you're describing primary versus secondary lesions, a primary lesion is something that develops spontaneously directly due to the underlying disease, whereas a secondary lesion comes from a primary lesion or is caused by the patient. The primary lesions can appear and disappear quickly. They can be transient. So in some cases, you need to be quite observant or see the animal quite early in the course of disease to identify those. And secondary lesions such as alopecia, epidermal collarettes can give clues about the presence of previous primary lesions. Some lesions can be both primary or secondary, such as alopecia, and can be caused by endocrine, which is a primary disease, or scratching due to pruritus, which is secondary disease. Just to give you some terminology, which is important, and I refer to this all the time when I'm writing my notes. A pustule has pus in it. A papule is a solid lesion. A vesicle is filled with clear fluid, and a bulla is a sharply circumscribed elevation of the epidermis filled with clear fluid. So a bulla is greater than a centimeter, whereas a vesicle is less than a centimeter. A plaque is a flat elevation in the skin greater than a centimeter in diameter, whereas a macule is a circumscribed flat area of color change less than a centimeter in diameter. A patch is flat versus the plaque, which is elevated and greater than a centimeter. And a wheal is the type of thing that we see in skin testing. These are sharply circumscribed raised lesions consisting of edema. A nodule is greater than a centimeter in diameter versus a papule, which is less than a centimeter. And a cyst is an epithelial lined cavity containing fluid or a solid material. The most common secondary lesions that you're going to see are epidermal collarettes, which are scale arranged in a circular rim of loose keratin flakes or peeling keratin. And it represents the remnants of a roof of a vesicle, bulla, pustule, or papule, Usually these are seen in association with bacterial pyoderma, but you could also consider immune-mediated diseases, fungal diseases, insect bite reactions, or allergic diseases. And excoriation is an erosional ulcer caused by scratching, biting, or rubbing, and just indicates that the animal is pruritic, usually due to allergies or parasites. Erosions are shallow epidermal defects that don't penetrate the basal layer. So again, going back to our diagram, if we look over to the epidermis, the basal layer is here. And then if we look over to the right, to this other diagram of the skin, an erosion would be one that doesn't penetrate this basal layer, whereas an ulcer goes below that. So then you might see bleeding because at this level that there are blood vessels, which there aren't in the epidermis. Secondary lesions also include things like lichenification, which is thickening or hardening of the skin, often hyperpigmented, usually a response to friction or inflammation. Common for these to have bacterial or yeast component to them. And a callus is something like this elbow callus here, which is thickened, rough, hyperkeratotic, alopecic, and often lichenified plaques. Commonly due to pressure and chronic low-grade friction. And the elbows are a very common area, also hocks and sometimes hips and sternum. So just to break up all the information relevant in the current environment, as somebody that's lived in Melbourne, I can definitely testify that that Victorians would be horrified at instant coffee and wouldn't go anywhere near it. So this is a good way of keeping them out of New South Wales, although at the moment it's more the other way around. Good preparation is really key to a dermatology consult. So, so if you know that the owners are coming in about a skin problem, it can be quite good to have a form that you can, or your nurses or receptionists can send to the clients before they come in, or it's something to give them while they're waiting, which can save a lot of time during the consultation. For example, diet, there's a certain type of client that if you ask them what they feed the dog, they start out with the lovingly prepared toast in the morning or the smoothie, and then they're talking for about half an hour by the time you get to the bedtime snacks, which they might get on alternate days, and it just can go on forever. So if you get them to write it down, if they feel like they've been heard and haven't missed anything out, and you can just extract the relevant parts that you need. This is an example of a kind of form that we send through with every time we book in a new client. And we ask them, this is something else, again, you learn from experience, is you ask the client what they perceive to be the main problem is that they're bringing their pet in for. It might be absolutely plain as day to you that it's got pemphigus, or it's got allergic skin disease, or it's got Demodex, but if they think the main problem is something else, then they're just not engaged with you from the beginning. I also like to ask them how long the problem has been a problem, although I've found that clients are notoriously underestimate the amount of time it's been a problem. When I read the referral notes, and it started back in 2013, but they tell me it started 2 months ago. This is where it is quite good to have the notes and the client form to put together and try and, again, just get an understanding of what their perception of the problem is. Also, it's important to know what area of the pet's body is involved, seasonality, whether this question about other pets is obviously mostly relating to ringworm or fleas. And then, as we talked about, the diet question. This, I think, is probably, if you were to take away one thing about how to manage your cases best, I would say managing owner expectations is probably the biggest thing I've learned since I've been in practice. And common things that I hear is that they think that the local vet is useless because they give them drugs, and when the drugs stop, the problem comes back. And it's my job to explain that their vet is actually doing a really good job. They're prescribing completely appropriate medications, and that it's normal for the problem to come back when a medication stops. And I try and explain to them that it's just like eating lunch. You know, once your lunch is digested, then you need to eat dinner. Like, that's not a problem. That's a normal fact of life. It doesn't mean that the food was bad or the medicine's not working. It's just how drugs work. While they're in the body, they're having an effect, and when they're out of the body, the effect stops. So it's just like eczema, hay fever, or asthma in a person. It's not something which you cure in general, and your aim is not to never have a flare up ever in the animal's life ever again. And this doesn't mean that you're a bad vet or that there's something wrong with your drugs. This is just what the disease is. Flares are not unexpected. And this is something that I'm constantly counseling clients on, is they might be really, really well controlled and they have one flare up in 5 years, and then they come in thinking that things aren't working. And you just have to put it in perspective and say, look, this is your first flare up since 2015, whereas before you were having 15 a year. So it doesn't mean that what we're doing is not working. And then if people do want something which is not like a drug, which is in the system and then out of the system, then this is where skin testing and immunotherapy is a really great option for a committed owner that really wants to get to the bottom of the problem and try and make some permanent changes. So atopy or environmental allergies, just like in people, hay fever, eczema, and asthma, triggers such as dust mite and pollens. The great thing that we're able to do now, largely thanks to Alan Bell bringing in the allergens a long time ago now, means that we're able to do skin testing for allergies, just like they can in human medicine with prick testing or patch testing. And we're looking for allergen-specific IgE that causes a wheal and flare reaction. So in people, they tend to do this on the arm or the back. And in animals, we tend to do it on their side. We have a panel of about 50 different allergens that we test for. And we're looking for these red raised wheals in the skin to tell us what is triggering their allergic reaction. Once we've found out and identified what the inciting allergens are, we can make a desensitizing vaccine. Sometimes owners don't realize there's a point to skin testing, and they say, well, there's no point in doing a skin test because I can't avoid pollen. But we're not expecting them to avoid pollen, just like a person with hay fever can't avoid pollen. It just means that you need to desensitize the animal or the human rather than changing the environment. So immunotherapy involves the owners giving injections at home. And we say to people that freak out a bit at that idea that it's just like diabetics, it's not a big deal. And it works really well in about 80% of animals to make them much less itchy. And if they want an alternative to giving medications and drugs, then this is it. Immunotherapy is a pretty miraculous concept. It works to teach the immune system not to overreact to these normal environmental allergens. It's not immunosuppressive, and it's fairly unique in that, which is why it's the healthiest treatment that we have. And desensitization is the gold standard for treatment of atopic dermatitis. So the body learns to tolerate these allergens without danger signals. What normally happens with the pollen is that it lands on the skin or it's inhaled, absorbed through the skin, and then the immune system of the skin receives that allergen. If you're an allergic type individual, then your immune system attaches a danger signal to that allergen before processing it. Whereas if you don't have allergies, then your immune system lets it pass. So by introducing the allergen under the skin or under the tongue, the immune system is exposed to these allergens without danger signals and learns not to react to them. So the whole cytokine environment of the body is changed, and it can have some very long-lasting effects. And in some cases, animals can be cured of their allergies. It's the only treatment which this is a possibility in. It's really effective in the vast majority of patients, although not every single patient. And this is where client expectation management comes in. We do say to them that it is possible they could go through this whole process and be one of the minority of people at the end of it, which it hasn't worked for, which is disappointing. And we can't tell that from the beginning. But it's as it's effective in the vast majority, it's well worth a go if it's financially possible and if they're committed enough to undertake the whole course of treatment. We do have an option of sublingual immunotherapy where the drops are given under the tongue rather than injections under the skin, which is a lifesaver for some dogs and owners that really don't like needles. So back to the best kind of tips and tricks. So good reference resources, booking enough time, managing owner expectations. And then the next one on the list is getting an accurate diagnosis. So it goes without saying that this is absolutely critical. Probably the most important thing I learned as a resident is that if you miss this step, which you do when you're learning, and you are tempted into different treatment trials, trying to you get pushed into doing what the owner wants, which is just a pill. And if you miss this step of working out exactly what's going on, you end up going around in circles with different treatment trials and owners getting more and more upset with you. So again, absolutely critical tip that I can give, if only one thing tonight, would be to say that diagnosis is critical, and some of the tools we have, don't underuse those, such as cytology, skin scrapings, biopsies. An accurate diagnosis makes your job a lot easier. I always now offer the client a whole range of options from nothing to prednisone to immunotherapy to biopsies, the whole range. So I realized that with experience, when I think I know what the problem is, I have started to offer shortcuts to clients more often, particularly those who I think may not financially be able to do gold standard diagnostics. But watching one of these Lincoln Institute webinars recently, it just made me have a think about what I'm doing again, and realizing that we can't, we all know this anyway, but it's good to be reminded that that people often do want the absolute best treatment that they can offer their pet, and that you can offer them, even if it does cost money and it is hard work. So don't leave this step out or make assumptions about what the client wants. Experience in this sense can be a good thing and a bad thing, because often you are going to be right with what you think the diagnosis is, but it's bad if it means that you're wrong and you do miss something out. So I guess this webinar just served to remind me to go back to basics, give the whole range of options, work with the client. I'm completely non-judgmental about their finances or their level of commitment. I just want to do what I can to help that animal in front of me. And I will encourage the client, if they can, to do gold standard, but whatever is going to the client is going to do, be committed to, and feel comfortable with is what I want. So just a few pictures to break it up a bit. The road to specializing. So I did my dermatology residency in Melbourne between 2010 and 2013. This is what my dining room table looked like for at least 3 or 4 years. Was just a lot of textbooks, a lot of Post-its, a lot of energy drinks, and some Labrador support under the table at all times, and some really good friends that towards the end, when I was beginning to lose my mind and was doing 12-hour days just sitting at this table, they dropped me off some meals, and one of them was this ready-made pie down in the corner that when I took the lid off to heat it up, my friend had put this little message on saying it's nearly over. So yeah, lots of study of immunology, histology, pathology, and put on a lot of weight during this time. And eventually in 2014 got the certificate, which was a great relief. So this is a recent picture taken just as we went into this level 4 in August. And this is Ellie, my amazing nurse, ready for action. And she has taken these next few videos, which are coming up in the next few slides. So tools for diagnosis. Cytology, it's hard to do when you're in a rush, so try and make sure you've got enough time to do it. And it would be unusual for me not to do cytology in every case. I would be absolutely lost without it. I just wouldn't know what I was doing. So you don't need much equipment to do this, just sellotape, slides, cotton buds, and a pencil. For skin scrapes, a scalpel blade, paraffin oil as opposed to immersion oil, and a cover slip. and fine needle aspirates, syringes, needles, and a slide. And practice is extremely helpful in knowing what you're looking at. I remember when I did zoo work as a vet student, I had no idea what I was looking at. And but slowly with practice, you get used to it. So if I didn't have a microscope, I actually just would consider going home and rebooking people, because you can't do a good job without doing cytology. Whether you do a tape prep or an impression smear, it depends how wet the skin is. If usually I just use tape, but if I saw a case like the one in the top right where there is just a lot of material on the surface of the skin, then I'll use a slide and press it on directly to do a direct impression smear. Choose really carefully where you're going to stick your tape or your slide. And you do get a very different result depending on how good you are at choosing where you take your cytology from. So sometimes I get animals that look normal, but the owner says they're constantly rubbing their lip folds or licking their feet. So I just ask which part the dog or cat is paying the most attention to. And I'll have a really good look at those areas. And even if the skin looks normal, I'll do some cytology and see what's going on there. And it's amazing how often you find things, even when the skin looks normal. So I'm just going to, hopefully this works, play a couple of little videos now. They are a couple of years old now, but I think that they're really useful. And I do apologize if they're too simple or if you've seen them before, but this is the kind of thing I get asked most often. So I thought it was really important to show you them.
Of the foot of a dog for cytology, we just take a piece of sellotape and then have a look at the dog's foot. Dogs often have quite fluffy feet, so you need to get the fur out of the way and then apply the sellotape to the top of the foot. I like to push up with my finger from underneath to make it a bit easier. And I open a few interdigital spaces, really look for the very red part of the foot. If I took a sample from over here, I wouldn't get anything. But if I really try for the red part of the foot, I'm much more likely to get a representative sample. So I have a finger underneath the foot, lifting the skin up, and then I'm just applying gentle pressure onto that to get my sample. Then I apply that onto a slide. Just sticking the bottom part down and leaving the top part loose so that I can put the stain underneath it, which we'll show you shortly. To do an impression smear of a crust, we find the crust in the fur and try and move the fur out of the way, hold the skin up, and then use the slide to try and get under the crust and make an impression of some of that material from under the crust on the slide.
If there is an intact pustule, you can rupture it with a slide edge or a needle and then directly press the slide onto the pus. You get some really good images doing that. It's particularly good for bacteria, and also if you're suspicious of pemphigus, to look for acantholytic cells. Okay, taking a skin scraping from a dog, you need a slide, some paraffin oil, and a scalpel blade. We start by putting some oil on the area that you want to scrape, and also some oil on the slide, and some oil on the scalpel blade. Then you need to pinch the skin. Usually if the dog's awake, we'll give them a little scratch somewhere else to distract them from what we're doing. Pinch the skin to encourage the mites to come to the surface. Stretch the skin out flat again and scrape in with the direction of the hair, trying to keep the material on the oil on the blade, and then wipe that off on the slide and repeat until you get capillary bleeding, which you'll see as pinpoint red spots on the skin. So periodically wiping off the skin cells and material onto the slide and trying to mix it up in the oil. So we repeat again until we get that capillary bleeding.
which you will see as these pinpoint red dots appearing on the skin. That is how to do a deep skin scrape for Demodex mites.
This is where the anatomy is really useful in picturing what you're doing as well. The reason for the pinpoint bleeding is that that shows you that you're at the level of blood vessels, which is also the level that the hair follicles are at, which is where the Demodex mites are. So whereas if you were scraping for scabies, they're in the epidermal, in the superficial layers, so you don't need bleeding because you're not trying to get down that deep. Scabies don't live in the hair follicles, so just that knowledge of anatomy is really helpful. Trichograms are incredibly useful. Again, good tip, have a good pair of hemostats, not the ones that no matter how hard you try, they just don't hang on to anything, which always seems to be the ones which are in every practice. So good hemostats that grip onto the hair well. And really useful to look for Demodex in areas that are not easily scraped, like feet and around the eyes. You can also look for fungal spores on trichograms. You can tell whether the hairs are growing or resting, whether the hairs are an anagen or telogen, and whether the tips are broken or tapered, i.e. is the hair falling out or is it being scratched out? So that can be useful if the owners are telling you the dog's not itchy, but all the hairs are broken. And you can look for some pigmentary disorders like melanin clumping in those color dilute blue and fawn breeds that are losing hair and the owners are not sure why. Just a tip, when you're grasping the hairs for the trichogram, grasp them in the middle, so not the ends, so because you can traumatize the ends of the hair if you grab them with the hemostats, and then it's hard to tell if they're tapered or broken. And try and lay them all down the same way so that when you're scanning along the hair bulbs, trying to decide whether it's an endocrine disease or what's going on with the bulbs, they're all in the same place. So a good pair of hemostats, grasp the hair in the middle and put it in some paraffin oil on a slide. And this is what you're looking for. So top left is a telogen, an anagen hair. It's the bulb shape and it's growing. And this kind of shaggy bulb down here is a telogen or a resting bulb. And this one is a shaggy resting one as well. These are the tips. So tapered, it's likely to be falling out, and here broken, so likely to be being scratched out. Fine needle aspirates can give you a ton of information. There's a lot of debate about needle on, needle off, do you suction or not? And the answer as to how to do it depends on what you think the mass is. So if you think it's something that's like a lipoma or a round cell tumor that's going to exfoliate easily, then you just use a small gauge needle and aspirate with the needle off and redirect several times. The cells are quite fragile. And if it's a rock solid mass that you think you're not going to have a chance of getting any cells out of, then use quite a big gauge needle and try and use some suction.
To take a fine needle aspirate of a mass, we need depending on the type of mass, we need a 25 gauge needle or small needle if it looks like it might exfoliate well. What I'm worried about in this dog is a possible mast cell tumor. You can either have the syringe on or off. In this case, I'm going to have it on. So we just isolate the mass, introduce the needle into it, and then gently aspirate and redirect the needle a few times. And then pull out, detach the needle from the syringe, and then put some air into it and reattach, and then blow out the contents onto the slide and repeat. We can also do it with the needle off. And in that case, you just introduce it into the mass and redirect a few times. And then take the needle out, draw some air into the syringe and express the contents onto the slide, and then smear.
Lymph node aspirates. There was a really good article in the Vet Script in 2017 by Sandra Forsyth, who's one of the brilliant teachers at Massey. When I was there, she was just brilliant at doing ClinPath and teaching us. And this article is a really good one, talking about using a non-aspiration technique with a small gauge needle for lymph nodes, because lymphocytes are very fragile, especially the neoplastic ones. They're not adherent to other cells and not embedded in a matrix, so it's easy for them to exfoliate. So she suggests moving the needle sharply forward at various angles to get plenty of cells, and reduce blood contamination with this non-aspiration technique. So she just oozes them out of the needle hub rather than blasting them out by placing the tip of the needle on the slide, and just gently use the slide over slide technique to make a thin smear, which helps with the evaluation. And this picture I thought was really good about the difference between aspiration and non-aspiration techniques. So the one on the left is the non-aspiration technique, in which you can see the structure of the lymphocytes a lot better, versus the one on the right, which was the aspiration technique, which has got a lot more blood contamination. It's harder to interpret. Another point she made, which I thought was really interesting, is that metastatic cells enter the lymph node just under the capsule. So it's more sensitive to aspirate the edge of the node, not the middle. And yeah, it's just another COVID-related image to cheer us up in the middle of a webinar. So staining samples, I just use DiffQuick. People ask me all the time about grand staining. I don't bother doing that. I just use DiffQuick. If it's a direct impression smear or an ear sample, it goes through all the 3 stains. And if it's a tape prep, I just put purple stain under the tape. Use a tissue to blot it out. Look on ×4 to start with, and look at anything interesting, which is the light purple areas with neutrophils in usually. Aim for those, go to ×10, and then put immersion oil on, and then rotate round so the 40 times doesn't go through the oil, and go straight to 100. Setting up the microscope depends what you're looking at. If it's tape prep or impression smear, then the light should be bright and the stage up, and with the condenser or diaphragm open. But if you're looking at trichograms or skin scrapes, then the opposite. So light dim, stage down, and condenser closed to increase the contrast.
So we have our samples here from the ear swab and from the foot taping, and we've come out to the microscope. So the first thing to think about is how the microscope is set up. We start off on the 4 times objective lens, switch the light on, and make sure that the condenser is in the open position so that we're getting the maximum light, and that the light is turned to maximum as well, because we're just looking at an ear swab and a tape prep. If we were looking for Demodex mites on a skin scraping and we had paraffin oil on the slide, we would want to have the light dimmed a bit. We would want to have the condenser partly closed, and we would want to put down the stage, which is a little button on the side, which puts the stage down, and that increases the contrast, so it makes it easier to see mites. But for normal slides, we have the stage up, the light on, and the condenser fully open. To stain the slides, we use just DiffQuick stain. We put the ear swab in the alcohol, which is stain 1. And then for the foot swab, we just peel the sellotape, the edge of the sellotape up, and you can just use a dropper bottle or a 1 ml syringe to go into the purple stain and put a drop of stain under the tape, and then spread that around a bit. We then give the ear slide a few dunks in stain 1 when the fixative, and then move over to stain 2, and just use a piece of paper to gently blot out the excess purple stain from the tape slide. That one's ready to go now. We just again dunk the ear slide in stain 2 for a bit longer, wipe any excess off, and put that in stain 3. Give that a little bit of a swirl around, dunk it in and out a few times, and then we just rinse off the excess stain, wipe that on the side, rinse off the excess stain with plain water, and then we can just use a plain piece of paper to blot that. So blot it on the non-stained side first, and then just gently blot on the other side, turn it over and wipe the back, and now this one is ready to go as well.
So what are we looking for when we look under the microscope? The main things you're going to see are all on this slide. So we've got a neutrophil here with intracellular cocci. These are rods, and then a whole storm of cocci here with smushed out neutrophils. These peanut-shaped structures are Malassezia yeast. This little bullet-shaped thing is a pollen. These are eosinophils, and these are fungal elements, which are quite cool looking. Rods, cocci, yeast, and fungal elements. And these are ringworm Microsporum canis spores, which are one of the most useful things you can find on a tape prep. So I really wanted to show you guys these ones. If you see these, that is diagnostic, that the animal has ringworm. It's going to save you. It's a really quick, instant answer if you're wondering what's going on. You can also see some other things under the microscope, which are quite weird and wonderful. So these are all pollens. And then you get these grenade type structures, which are environmental mold spores. So you've got alternaria here and curvularia here. A trick for young players. On the right, we've got cocci with a background of neutrophils, and something to watch out for are melanin granules, which are golden brown when you focus up and down, and they're usually focused over a keratinocyte. So don't be confused by these brown regular structures, which are melanin and not bacteria. Nucleated keratinocytes are something that you see with increased epidermal turnover. That's also quite something that you'll commonly see with scale. Demodex and scabies mites. Demodex are here on the left with an egg and a juvenile, and then scabies on the right. So some mites are surface mites that live in the epidermis, and so the Demodex cornei, or the short-bodied Demodex, lives in the epidermis, and as does scabies. So superficial skin scrapings to find these. You won't find them on trichograms because they don't live in the hair follicles. And if you're suspicious of Demodex, just do your deep skin scrapings until you get capillary bleeding. And that's how you know you're at the right depth. This is a case I saw when I was doing practice in Cornell in the States, of a poor bear that had scabies that was just starving because I think it was just so itchy. It was unable to do anything else apart from scratch. So this is a post-mortem photograph, and pretty sad. So this is an actual scabies mite which was found on the bear. And then you also have on trichograms here, you have the normal Demodex mite, and these are the adults with 8 legs. And looking at all of that makes you realize that you feel pretty disgusting after a day at the office. So bacterial infections can present in a few different ways. Hot spots, pimples, pus, red spots, oozing skin. It's a useful tip, again, is when you're trying to decide how to treat these things, is that surface infection needs a topical treatment and deep infection needs antibiotics. You want to target your treatment based at where the infection is. And again, this is where your anatomy of the skin comes in. So if it's a deep infection in which oral antibiotics which get into the bloodstream are going to reach that infection, which is down around the hair follicles, you want an oral antibiotic. And if it's a surface infection in which your blood-borne antibiotic is not going to reach, you need a topical. And then it's also important to think about predisposing causes. Another thing which you really commonly see on the skin is this yeast overgrowth. Yeast love warmth and moisture. So when an allergic dog is licking and chewing their toes incessantly, making them warm and wet, the yeast think it's fantastic. They overgrow and release more enzymes that cause itch, which is a vicious cycle. Something I've learned in practice over a long time is you don't always have to try and sterilize the skin and treat every yeast. Often, if you treat the allergy, it solves the problem without treating the yeast at all. Another good tip of how to communicate with clients with contact dermatitis, which clients are always wondering about. Kikuyu grass and wandering Jew or Tradescantia are the two most common offenders. It can be quite good to have a plant of wandering Jew or a picture in the consult room to show the clients. And a really important thing is that contact dermatitis just only affects the part of the dog that touches the plant. So if they've got conjunctivitis and ear disease, then it's not a contact allergy. So I try and describe it to clients by saying it's like a jewelry reaction in a person, and it only affects the bits of the dog that touch the plant. Haha, good old Donald Trump. So food and environmental allergy, they look exactly the same on the dog. So focused on the eyes, ears, paws, armpits, groin, under the tail. An important question, the most important question to ask is in regard to seasonality, because if the client says it's only a problem every February and March and the dog's fine the rest of the year, it's not going to be a food allergy. If it's non-seasonal, then it could be either problem. These are the areas affected. People often come in and say, have you ever seen anything like this before? And the answer is yes. And then when you show them a picture, they realize that you have seen it before. So a good communication tool. Food allergies and diet trials. Again, common things that owners will tell you is that it can't be food as they've always eaten the same food and nothing has changed. This is wrong. The animal needs to have eaten the food in order to develop an allergy to it. If they've never ever eaten the protein before, it's unlikely to cause an allergy. Thus the basis of novel protein diets. So people and animals can and commonly do develop food allergies later in life to something they have eaten for their whole life. And again, if you have a slide like this to show owners, to make them understand that this is not the first time you've seen this, it just helps them buy into and understand that you have seen it before. And if it's written down, they tend to believe it more than if you're just saying it. So the only way to tell if a dog has a food allergy or not is to do a diet trial. Blood tests are not reliable, so don't bother. And allergenic, we're really lucky to have this. The diet trial needs to be strict. It needs to last for 8 weeks. And common things that we tell owners is that they can't give other treats like pig's ears, dentistics, and hypoallergenic treats, toothpaste, worming tablets, antibiotic, and flea treatments that are flavored. And the reason that analergenic is a really good option is that they have such strict cleaning protocols in the factory, and they do PCR on the final product. So there's a much reduced risk of cross-contamination. It is made out of feathers, so some people find that a bit crazy. The other option, if the client doesn't want to do a dry food diet trial, is to do a home-cooked diet trial. You need some supplements like vitamin B1 for this. And it's important to remember that if the animal is not fully grown, then analergenic is not an appropriate diet for them. And it may not be appropriate if they have other health problems like renal disease or urinary disease. So if there's anything complicated going on, we often rope in a nutritionist to help us formulate an appropriate home prepared diet, or we ask them if they think analergenic is appropriate. And we give them all the information such as the breed, age, stage of growth, and any other requirements, just to make sure that we're observing the first principle of veterinary medicine and human medicine, which is do no harm. Another thing which appealed to me in these COVID times, I love this one. And this, thanks to Ellie, this is just gold. And as she pointed out, the funniest thing about this announcement was the looks on the faces of Dr. Bloomfield and the sign language interpreter, wondering how she is supposed to interpret this. So hopefully I've more or less stuck to type. Coming to the end now. Coming up really shortly is the European Veterinary Dermatology Congress, which was due to be in Porto, but unfortunately has gone online now. So that's the 16th to the 18th of September. It may have already passed by the time you see this webinar. But next year, the American conference is due to be in New Orleans in April. And then also the European one is going to be in Porto in September again. So the dates for the North American conference are the 27th to the 29th of April, and the European conference will be the 28th to the 30th of September. So if we're able to travel by then and able to get out and about, those will be two good conferences to go to. So just to conclude, thank you very much for listening. I know it's hard to set aside time to do CPD when all of us are struggling so much with the circumstances that we find ourselves in. So thank you very much for your time tonight in listening. I really appreciate it. And best wishes, and look after yourselves.